So continuing on with our medical emergencies, we look at Chapter 10 for poisons and substance abuse. We're still in the medical emergencies, so we'll kind of muddle through this. We talk about toxicology. We're looking at mainly any kind of poison. So we're going to focus on different types of poisons, including carbon monoxide and nerve agents, and then how and when to contact Poison Control Center. We're also going to look at things that enter the body that create what we call allergic reaction, and a severe allergic reaction is called anaphylaxis. A little bit on pharmacology that we can help somebody self-administer or administer to a peer in an emergency. So when we look at medication administration within the scope of practice of the EMR, we want to make sure that as much as possible that person self-administers, which means that if they were going to take a medication anyway prior to the ambulance arriving, that they take it. Peer administration is that you actually look at it and say, hey, do you have maybe somebody that's got a respiratory problem, do you have a inhaler? And you go grab that for them and you peer administer it. So those are the ones we look for. So within the scope of practice for the emergency medical responder, you have to be familiar with the names, effects, indications, something we call contraindications, reasons that we don't give it, routes of administration, and then the dosages. So look at it this way. There's 6 medications that you could potentially, or 7, potentially give to a patient. 3 of them you'll carry in your first responder kit or on your ambulance. And those are going to be oxygen, instant glucose, which we kind of talked about in medical emergencies, for somebody that's awake, and we rub that on the inside of their cheek. Activated charcoal, which we'll talk about today, for poisons that somebody could have. And then the other ones are maybe medications that the patient has on their own. For somebody with chest pain, maybe aspirin and nitroglycerin. Bronchodilators, whether they be a handheld inhaler or a small volume nebulizer for a situation like asthma. And then the EpiPen auto-injector for an allergic reaction. So we want to be familiar with those, at least, just 7 medications that we can assist somebody in taking should they have their own medication. So basically a poison is anything that enters the body that causes harm. So if somebody takes a medication that normally is good for them, but they overdose on it, then that's a poison. If somebody takes a substance that, whether it's eaten or it's drank, or inhaled or injected or whatever, even in small quantities, that's a poison. And so what we want to do is really recognize and think about treating those very early on. So we look at how a poison enters the body, and there's 4 main ways. They can eat it. It's ingested through the mouth, absorbed in the digestive system. Again, it can be medication that's intended for one thing, and they take it for something else or change the dose. A poison could be something that's inhaled, whether it enters the mouth or the nose, but it gets absorbed either in the mucous membranes or in the respiratory system. So an inhalation could be carbon monoxide, it could be a noxious acid or an alkali or something like that. It could be injected. And so we think of injected medications or injected poisons like maybe illicit drug use, but it could also be venomous. It could be snakes and spiders or ticks or something like that injects that poison into them. And then the last way is absorbed. And probably the easiest way that we look at absorbed poisons could be poison ivy or poison oak, or maybe a chemical that is dry, and then when it gets on the skin, it gets activated by that patient's sweat. So we think about poisons, we always have to think about that scene size up, and is it safe for us to enter? And generally, if there's more than one person overcome by a poison, we don't enter. There's multiple sites of people that went into a situation, and maybe there are 2 or more or 20 people overcome by some kind of fume, and then pretty soon all the responders start collapsing. The sarin gas attack in the Japanese subway is the best example of it. There was a camera crew down there in the subway filming a commercial, and when the 2 chemicals, the sarin gas, mixed, and everybody down there started collapsing. Well, the camera crew collapsed, the camera kept rolling, And it's quite interesting. It's a good take on this. Is the first responders came down the stairs of the subway and they collapsed, and then more came down, they collapsed, and more came down, they collapsed, and then you had to imagine up top, up on the street level, somebody finally said, "Don't anybody else go down there." Well, how many people succumb to this before that happened? So think about your own safety on this. Our general assessment is following that patient assessment sequence so that we can, number one, make sure the scene's safe, and then get that history from the patient of what happened. Was there a sting? Was there a bite? Was there a noxious odor? Was there something that was absorbed? Were they, in the woods or something like that where they could have got a tick or poison ivy or something? So looking at those signs and symptoms, this gives you a little bit of information as to what it is. When I took EMT school, they always talked about, bring the substance with you. Okay, well, if somebody got cyanide poisoning, I don't want to have cyanide gas in the back of the ambulance with me. If somebody got bit by a pit viper, I don't want somebody bringing the snake with me. So not necessarily do we do that. Ingested poisons. More than 80% of all the poisonings are caused by something we ate or drank. So these could create chemical burns, odors, or stains about the patient's mouth, just something that's abnormal. And what we really look at is it an acid, an alkali, or a petroleum product? Because those will actually create holes in the digestive tract and cause some internal bleeding. So signs and symptoms can be any of these, including lower abdominal problems that they could have from there. So we think about, what did they ingest? What is it that they took? So when we contact poison control, and the number's there, 1-800-222-1222. They're going to ask a lot of information. They want to know about the age of the patient, the approximate weight, any medical conditions, everything. But the three most important pieces of information that you need to gather is what was the name of the poison, how much did that patient take, and when did they take it? Because that's the three most, if somebody took something 3 days ago and now they're kind of itchy, that needs to come into play. What time did they take it? So if you're unable to contact poison control for whatever reason, the best thing that you can do is dilute. Dilute whatever it is with water. There's some of them that if you actually get poison control, they'll dilute with milk, but for the most part, dilute with water. We no longer try to get them to throw up. If they lose consciousness and then they start throwing up, that could affect their airway. So three most important pieces of information and how to contact poison control. So most poisons can be diluted. You think about an absorbed powder on the skin. We dilute it. So in order to dilute it through ingestion, through drinking, that patient has to be conscious. Otherwise, they're not able to protect their airway, and they have to be able to swallow. One of the drugs that you'll carry either in your first responder kit or on the ambulance is activated charcoal. And it's a finely ground powder that's mixed in a slurry with water. So you have to shake it up a little bit because it's already mixed, and it works by binding to the poison. And then most of them nowadays come with sorbitol. And sorbitol is not so much a sweetener that it makes it taste better, because activated charcoal is really just a tasteless, odorless, gritty powder that they drink mixed in water. The sorbitol is not to make it sweet, to make it palatable. The sorbitol is there to act as a laxative. So if they have something that it binds to in their stomach, then they rapidly excrete it by pooing it out. We don't give anything by mouth, water or anything else, if they ingested an alkali or an acid or a petroleum product, because those could create holes in the esophagus and in the stomach, and definitely not if they're not able to protect that airway and drink. So this is the Actidose with sorbitol. It comes 50 grams in this container, and it doesn't look like much to drink, but you'd be surprised how many people will not drink that out of a glass. The best way to do it, and I've had to give it a few times where pre-hospitally, where we had a styrofoam cup with a lid on it, put a straw in it, and they'll drink it that way with no problem. A water bottle, to dump out the water, leave a little bit in there, helps it mix, and they're willing to drink it like that, but to drink it in a glass and see how dark it is, they may not. The usual dose for an adult is half to a full bottle, and then a pediatric would be a fourth of the bottle to half of it, so 12.5 to 25 grams. And like I said, it's better if you cover it in a cup and then give them a straw to drink it. In old days, we used to give this stuff called syrup of ipecac, and people would vomit. They would vomit profusely. I mean, you gave them the trash can, and they would fill the trash can. The problem was it took about 20 minutes to work, and in that time, if they lost consciousness, now we have somebody who's unable to protect their airway, but they're going to vomit. So EMS doesn't carry this pre-hospitally, and activated charcoal seems to be the best thing. For somebody with an inhaled poison, so again, toxic substances like carbon monoxide. Carbon monoxide is tasteless, it's odorless, it's, doesn't create any fumes or anything like that. But people will say, they got a headache, some roaring in their head, maybe some ringing of the ears, and it's cumulative. So people that smoke may run, 3 to 4% carbon monoxide normal, and this is cumulative. We were talking about the cherry red skin, and that's actually a very late sign because it will bind with red blood cells. Instead of carrying oxygen, they'll carry carbon monoxide. Other toxic gases like chlorine gas. Chlorine is very heavy, and like its name, is green. And you can actually see that coming down the road, like from a railroad derailment or something like that. Ammonia is very pungent. It burns the nares as you breathe it in. So both those gases are very irritating to the respiratory tract. That's why at scenes that have any kind of chemical spills, we try to stay upwind and uphill. Let the wind blow it away from you, not towards you. And if it's something that's flowing like a liquid, let it flow away from you, not towards you, so you stay upwind and uphill. Inhaled poisoning, these are some of the signs and symptoms that you can see, and one of the most common is that headache, sometimes hoarseness and coughing, depends on how toxic that is. And carbon monoxide is one of those that doesn't really create any of those problems other than headache and, just kind of like you're not really with it. But it usually comes in the wintertime from improperly vented heating appliances. A lot of people in the wintertime, maybe they don't have a great heating source, so if they have a gas stove, they'll turn on the burners, and they'll stay warm in the kitchen like that. I mean, flames will put off a lot of heat. Unfortunately, there's nothing to take that waste product of carbon monoxide out of the room, and it's cumulative. So, and the same thing for burning buildings. Usual signs and symptoms that you see with that, and that cherry red skin is a late sign. We always say cherry red, they must be dead. And I've seen a couple like that who are very dead. So it is that way. So treatment for this, though, is fresh air. Unless they have high concentrations of carbon monoxide, then we need to get them into hyperbaric treatment pretty quick. So you can be shipping them to a larger hospital to get that done. Like I said before, ammonia is an irritant. A lot of times you'll see it in agricultural settings, in fertilizers, and it's a very irritating odor. So it creates that violent coughing and the skin burns. So anybody that enters that area needs to have a self-contained breathing apparatus, like a firefighter, to not have that in their own lungs. And so you can see some chemicals here, spraying this, and then the suit that they would, or the gear that they would need to wear to go into that environment. When we talk about hazardous chemicals, anything that could be cumulative to you, maybe it wouldn't kill you today, but in the long run it could. We want to make sure that we're prepared to go into that environment. And if you're not, you have to stay upwind, uphill, and wait for that person to come to you. So we call that area the hot zone. We decontaminate people who have been overcome by any kind of hazardous materials in the warm zone. EMS works in the cold zone. So we stay where there is no irritants or contaminants or anything like that. Same thing for chlorine. It's very irritating to the lungs and upper respiratory tract. You'll see people violently coughing. It burns the skin. We stay in the cold zone. Whoever goes into this area needs to be properly equipped. And ways that we know to look for this stuff is looking for hazardous material placards. And all of these mean something. The little fire means that it's flammable. Some of them mean that they're corrosive, and others mean that they're combustible or irritants. So we have an emergency guidebooks that we look up these numbers, and I'll use binoculars to see these numbers on these placards. I'm not going to get up close and go, oh, look, it's 1824. No, I wear binoculars to see that. I don't want to get so close that I'm able to read that. Best treatment for inhaled poisons is fresh air. Oxygenation, get them out of the air as soon as possible, decontaminate them, and assess them. So if they're not breathing, we have to breathe for them. And if they are breathing, then we need to give them high concentrations of oxygen via the via the non-rebreather mask. Keep that air flowing in the ambulance. Open the windows, get that fresh air in there, especially for that. On injected poisons, two major causes of poisons are animal bites and stings, and then toxic injections. So when we look at these animal bites and stings, we want to look for bite or sting marks. And everybody, is really worried about bloodborne pathogens that mosquitoes can carry. Can they carry HIV? Can they carry Ebola? Can they carry the Zika virus? And AIDS, HIV is a very wimpy disease. I'm not worried about that. But some of these others, dengue fever, they're real. And the more rain that we get, the more chance of having a more populous mosquito year. So this can cause a problem. Main thing is to keep the patient still. The more that they move around, the more they spread that venom throughout their whole body. We don't really use constricting bands anymore, but if there's some severe swelling, you may be directed to do that. If it's a sting, like a bee sting, the honeybee, when it stings, it embeds the stinger into the skin, and it flies away and the stinger stays there. So we have to get that stinger out. There's a little pulsating sac at the end of it, and it continues to pump the poison into the body until it's removed. So we want to scrape that out. The reason is, if I pinch it, I squeeze that venom sac, and all of the poison goes into that person's skin. Some people may have an allergic reaction to this, so we have to look for signs of allergic reaction, which are they're itchy, hive, swelling. Okay, that could be a minor allergic reaction. But when they start wheezing and it feels like their throat's closing up and they're having trouble breathing, and then they show signs of shock like general weakness, loss of consciousness, rapid weak pulse, rapid breathing, that's anaphylactic shock. And we've seen people with this that if they don't get the EpiPen auto-injector really quick, there's a mortality rate attributed to this. People die from bee stings, from wasp stings, from eating peanuts, from things like that they're highly allergic to. So lay them down on their left side for shock. Again, if it's a bee sting, remove that allergen. Don't let it keep pumping whatever it is. If it's something that they're exposed to, remove it if you can. Be prepared to do CPR if needed. And the ultimate treatment is going to be, if they have their own EpiPen auto-injector, is to place the tip against the outer thigh, the lateral outside of the thigh, and then just push it in. You'll feel a click. And you want to hold that pin in place for several seconds. Now, even though it's called an auto-injector, we think of a syringe. Notice this picture, how they do not have their hand on either end of that syringe. One end the needle comes out, the other end needs to be able to push back. And if you put your thumb there, you'll break it. So you just push it in, the needle comes out, it goes into the skin, and it injects it in less than 10 seconds. Epinephrine works great, it works quick, but they still need help. It's not like we give them the EpiPen and they're fixed. Most allergic reactions will take place within seconds to 30 minutes. After 30 minutes, if they're not going to have an allergic reaction, if they haven't had one yet, they're never going to have one. So you don't have to worry about that. Along with our injected poisons, we have to think about snake bites. So we have pit vipers in the United States, and then coral snakes. So rattlesnake, cottonmouth, and copperhead are all pit vipers. And your cottonmouth is also called a water moccasin. So those are all the same thing. Pit vipers have a triangular shaped head. They have heat sensing pits right below their eyes. And Pit vipers and vertical pupils. So 3 things identifying. My thinking is if you get that close to see that kind of stuff, you're too close to that snake. So the snake injects the poison into a person with its fangs. And here's a couple of examples of the rattlesnake. This one's got quite a lot of buttons on it, the little rattles. And you can see the triangular-shaped head, the vertical pupils, and the heat-sensing pits. They're reptiles, so they're cold-blooded. They'll do everything they can to stay warm. So you really see snakes after it's rained and their holes are flooded and they come up to kind of dry out and warm up. The coral snake, which shows it's coral because it's red on yellow, kill a fellow, they're very small and they actually have to chew their venom in. But the pit vipers tend to be what we call necrotoxic. They damage the skin. And your coral snakes are neurotoxic. They actually work by causing their prey to be paralyzed, especially the diaphragm for breathing. So like a small animal or something, a small bunny, then they go over there and eat it. Well, it can have an effect on an adult, especially one that has medical problems, but usually not so much. So pain at the site, swelling and tenderness, and you can actually watch that swelling and redness expand, spread throughout the extremity. And I usually think of the hands. All the pit vipers that I've had come in contact with as far as patients, they all got bit in the hand. They were under the influence of alcohol, usually hunting or hiking or something like that, and they tried to catch a snake like, oh, look at this, and then they got bit in the hand. So these things can all happen. Coral snake, you remember how it kind of paralyzes. It's more neurotoxic. It slows things down, and that's what it does if enough of the venom got into the person. So most hospitals would keep antivenom for both of these snakes, crofab for the pit vipers, and then the antivenom for the coral snake. So we no longer cut and suck. That's old school. We don't do it anymore. Number one, when we cut wrong in the muscle, in the skeletal muscle. Number two, I don't want to put my mouth on somebody's blood and suck their blood as well as the venom into my mouth. So we don't do that anymore. We do keep the patient calm and quiet, have them lay down, try to relax. If it's available, wash that bite area and then splint it. The less they move that area, especially in extremity, the less that poison spreads, and we can help by keeping it lower than the level of the heart. One thing we don't put on a bite, besides our mouth, is ice. Ice will actually cause a cryogenic reaction and make the venom more potent. So the biggest thing we want to do is arrange for transport to that hospital. It's a good time to kind of break up this lesson here.